Welcome to the IM Residency Prep Series. My name is Abi Apakudi, and I'm here with Neil Jrath. We are fourth-year medical students at the University of Michigan Medical School, and we'll be talking to you about altered mental status. I encourage you to download the Altered Mental Status One Sheet. This is an outline that will follow the format of our talk so that you can keep track of all of the information and clinical pearls in one convenient sheet. This video is meant for informational and educational purposes only and should not be understood as medical advice under any circumstances. Our agenda will be to start by defining altered mental status, followed by going over a basic approach in diagnosis and management, including immediate steps that should be taken, evaluating the causes of altered mental status, and conducting an appropriate workup. Altered mental status is a broad term, which can be differentiated from delirium and dementia. Altered mental status, or AMS, encompasses the findings of altered behavior and confusion, ranging from difficulty thinking to altered thought content or change in consciousness. It is usually first noticed by someone other than the patient. We won't get into the specifics of delirium and dementia here, but these are both specific causes of altered mental status, and they both might often coexist in the hospital setting. We have organized this talk, this basic approach to altered mental status, with a scaffold of acronyms that were modified from the Clinical Problem Solvers website. We start with the words "don't miss," as in you should not miss these steps first. Before getting into the specific approach for altered mental status, please keep in mind that the first step for any acutely altered patient should be to assess airway, breathing, and circulation. The general goal of the acute steps are to treat empirically for hypoxia, hypoglycemia, and opioid overdose. To this end, the DNR mnemonic stands for dextrose. If a point of care glucose is less than 70, give 1 amp IV D50. You can give thiamine first if it's available. The O stands for oxygen, and you can give 100% oxygen by face mask immediately, and assess whether the patient can protect their airway, intubating if this is not the case. N stands for naloxone and neuro. Opioid reversal treatment with naloxone is largely harmless and can quickly correct an overdose. N for neurologic causes, specifically stroke, should also be considered, and it can be helpful to do a quick neurologic exam to determine if there are any focal neurologic deficits. Finally, T for thiamine can be given before glucose if available for the theoretical prevention of Wernicke's encephalopathy. Next is MISS, addressing the causes that may need a more involved workup. M is for metabolic. If an electrolyte imbalance exists, you can correct it as needed. If the patient has a very high BUN, you can correct it with dialysis. If the patient has liver failure and is demonstrating signs of hepatic encephalopathy, give an osmotic diuretic like lactulose. If an ABG demonstrates hypoxia, respiratory or metabolic acidosis or alkalosis, the imbalance needs to be corrected. ACS can also present with altered mental status and can be diagnosed with an EKG and troponins. A TSH can be helpful in revealing a thyroid imbalance, and this condition may require treatment. Adrenal insufficiency should also be considered. Constipation should not be overlooked and can be diagnosed with history alone or an abdominal X-ray if necessary. Urinary retention can also be diagnosed with a bladder scan or urinary straight catheterization, which would also be therapeutic. Finally, nutritional deficiency such as B12 or thiamine deficiency should be ruled out and treated if necessary. I stands for infectious causes. In patients without an obvious cause of altered mental status, infection should be ruled out, especially in the presence of temperature changes, hypotension, or leukocytosis. Patients should undergo a UA, blood cultures, and a chest X-ray. LP can also be considered if meningitis is suspected, and other infections can be considered in high-risk groups. S stands for structural changes, including trauma, post-op changes, mass lesions, or normal pressure hydrocephalus, which can all be generally evaluated with a CT scan. Should be done non-contrast first to rule out a bleed. Other neurologic changes on exam can be helpful in finding other structural issues, and if there are any concerns for structural injury based on exam signs of clear rhinorrhea, battle sign, raccoon eyes, or depressed skull fracture signs, that can also be helpful. The second S stands for substances or toxins, which includes withdrawal, prescription, and non-prescription drugs. Get a urine tox screen to rule out some of these toxins, but keep in mind that some drugs do not show up on that screen. If the first two steps come up with nothing, other causes of altered mental status should be ruled out. Delirium carries many of the same risk factors and causes that were discussed previously, and is usually always due to an underlying medical condition. Correction of the underlying cause is the treatment, along with supportive measures like changing medication timing, normalizing sleep-wake cycles, controlling pain, and reorienting frequently. Dementia has its own differential and workup that we will not go into here. Again, if a stroke is suspected, specifically something like a thalamic or brainstem stroke, which can cause altered mental status, an MRI can be helpful. Seizures can also lead to altered mental status, such as through a postictal state. Sometimes seizures can be non-convulsive, and an EEG and/or an MRI can be helpful. Finally, other causes such as psychiatric conditions can be ruled out if necessary. So this slide just reviews what we have discussed in detail previously. Remember, don't miss and the miss negative causes for the workup of altered mental status. Thank you so much for listening to this talk. I know your time is extremely valuable. If you have any questions, comments, or suggestions, please feel free to reach out to us. Thank you again for tuning in to the IM Residency Prep Series.